I'm Justy Anthony Chiramal. I'm a clinician and I work as a clinical director for global health at Qure.ai in the product team. With me, I have Professor Heather Zard, who is the professor and chair of Department of Pediatrics and Child Health at University of Cape Town. Then we have Dr. Celso, who is also a medical doctor and director of ILS and CISPOC in Mozambique. And we also have Professor Dr. Stephen John, who is the founder of Janna Health Foundation in Nigeria and Director of Planning, Research and Statistics at Adamawa Ministry of Health. So as we know, we can start, we wanted to talk about, there is a lot of underdiagnosis and underreporting, especially in under 5 children. So we wanted to know, what do you think are the main challenges? Why is there so much underdiagnosis and underreporting? What do you think can technology help, especially AI, softwares, or digital health intervention in general?
Thank you. Thanks so much to be part of this. I think that's a really critical question in pediatric TB now. Today, for example, the WHO announced that more than 50% of children with TB are undiagnosed. So I think traditionally, people have regarded it very difficult to confirm microbiological diagnosis in children. Yes, I think that is not as true as it has, as people have regarded it. We've had great advances in microbiological diagnosis, both in terms of sampling and in terms of tests, right? And so we know that induced sputum, for example, is very feasible, even in young children, even in infants. And that could new rapid diagnostics, which are more sensitive for detecting TB. We have much better sensitive tools to detect TB. So that's the first point I want to make. I think we in the child community need to emphasize better diagnostics that are available for childhood TB currently, and to push this notion that, in fact, microbiological diagnosis can be made even in primary care. I mean, it's a standard of care for adults, right? And for childhood TB, I think we're also challenged by the frequency of co-infections, viral TB co-infections, bacterial viral co-infections. So these are challenges. However, I think there's been a lot of advances. We do need to bear in mind that, increasingly that children presenting with pneumonia in high TB settings, in fact, often have TB as well.
Diagnosis of TB in this young age group of 5 and below has been a challenge ever. It's something that we are, every implementer is struggling to see how they can go around it. And so are researchers. So are people that also try to come up with tools that will help us. Because you are dealing with someone, a person who cannot tell you what he's feeling, what the symptoms are, whatever experiences. So what can be done? What can technology do? We have seen what the X-ray with AI has been doing in the older age group. We have implemented a program for over 5 years to 14, that is older children, since 2022 with the help of Amin X-ray and Qure. And we've seen what that has added. Improved diagnostics, of TB, reduction of wastages of cartridges, this challenge of radiologists, accessing them, has come down. It's not that we don't access radiologists, but you don't have to be running all over the place like before.
That there's also a gap in terms of training. And I believe that the AI can also close that gap, because I would say that digital health is a very new thing. And if I look, for example, during my training, I did a dev training into digital health. So I believe it's also important to bring all the AI components, but also bring together the training that is needed for health professionals to allow them to use the tool as they are supposed.
I just wanted to add that we have developed an AI algorithm, as you may be aware, for pediatric TB. We've got data from certain areas, lot and diverse. But what we are seeing is, after enriching our existing AI algorithm with the additional chest X-rays from children who has TB, the accuracy has improved drastically. So we're currently in the process of doing validations, as you had suggested. So that is one update. And we are also in the process of integrating pediatric pneumonia guidelines and projects. So we'll talk about that as well. What do you think is the potential of integrating POP and other AI solutions? Maybe you want to start.
Yes. So I think, as Professor Anna said, integration is really important because you have several differential diagnoses. And even if we can say that it's not TB, then you need to find a solution for that child. And basically having other tools that can improve our toolkit for TB is really important. At the fault analysis space, I believe there are several initiatives to look at different patterns to identify TB, pneumonia, flu, and other respiratory disease. I think this is an area that is developing very quickly. There's a lot of potential here because first, most of the softwares now, AI tools, are working with smartphones. The penetration of smartphones is very high, even in low middle income countries. So basically, basic smartphones with a basic microphone are able to capture cough, and then this cough can be analyzed on the device on the cloud, and you can have a probability score for TB.
We clearly know there is role for NGOs, academic partners, national TB programs, implementation partners. So we just wanted to hear your insights on the role of these like global partnerships in general. So you have to see if you want to add something.
Yeah. Of course, no one entity, no single entity can do it all. We have seen the kind of challenges associated with TB prevention and care. I speak from two perspectives, both an implementer and then of course a government worker, and even three perspectives, having an organization that is private. So I've seen a situation. What drove me into having an organization was because I saw the limitations of government. Government is not able to deliver service all over its areas of jurisdiction. There are certain places that you go that are devoid of government services simply because it is hard to reach, it is too expensive, or there are not enough people that could take the services there. And this is where the civil society and other organizations now have to come in, and then this is what they're doing. They target these particular places because this is where you have the marginalized population, those that have a higher rate of TB. So you can clearly see already there are two important roles now for two different entities. Then, thirdly, the issue of funding now. Government needs funds, its budget. Most of our government, their budgets may not be able to reach. They need support from outside, from somewhere. The partners are there supporting organizations to carry out those particular interventions. So you can see now the partners have come in. We need support with funding. We need support with capacity building.
I also wanted to add like the AI algorithms, right? Like our X-ray algorithm is built on 9 million X-rays from diverse settings. But from what I understood from each of those sites and from what we've been speaking to our implementation partners, even the type of population, I think you alluded to it, the type of population, the setting, vulnerable population, what threshold to use. There is so much that it's not like a one size fits all, even within a same country, right? So I think it's so much collaboration is needed to keep improving the tool. What do you think is the scope for technology in general in managing all the other risk factors and illnesses as well?
When the X-ray came, the digital X-ray, AI, the first versions, it was only looking at TB. And we saw all these problems you're talking about. There are children with pneumonia, children with other lung infections, Some even have abnormalities that we saw. Children with larger hearts than normal, adults even, So that calls for an integrated kind of approach. And this is why we're pushing for integrated service delivery. If you look at what Stop TB Partnership is doing now, the last grants that was just wave 11 now, it's also about integrated service delivery. They started this like 2 years ago, looking for TB as well as other conditions that coexist with tuberculosis so that you don't leave people with those conditions. So what AI can do is for it to be developed in such a way that it can give you all these patterns, It can look for TB, can look for pneumonia, can look for silicosis, can look for post-TB lung disease, and all those kind of things. So that in one exposure, you can see a lot. So this is what it can do, and I'm happy that it has started because we are beginning to see that there are well, already those that are looking out for this kind of conditions, but it should be viewed region by region.
When we add HIV and also malnutrition, that's the diagnosis is harder in this population in children with other comorbidities. So I believe there we can see here a space for other TDAs. For example, there are recent publications on TDAs in children with malnutrition, but also children with HIV that are trying to improve the accuracy of diagnosis in this specific population.
AI technology has a lot to do with helping implementers and government taking services to the community, which is the point of view of the Qure.
Maybe I can add to that. I believe that one of the points where AI will have a lot is with the first kind of risk stratification and then disease severity. Now we are moving into an era of treatment where we look at these two parameters to define how long we should treat. And when we take into account subclinical TB is even more important, because then you don't want to treat every child for 6 months or for 4 months. Maybe you can have different regimens, but you can also different follow-ups. You can see some children more frequently or more closer because you know that they have a higher risk for complications. And that's a thing that only very, very well-trained physicians can acquire and takes time. So if AI can shorten that gap where you can basically improve your risk stratification and your severity classification, I think that will help a lot into how to treat better children and to provide care. So
Now, again, I completely agree with all the points made. And maybe just to add, I think AI has actually got the potential to reduce inequity here, to reach the children who aren't being reached. But not only that, I mean, if you think of the cost for a family, taking up work, coming to hospital, so the poorest children, the lack of access to care is not only about physically accessing care, where the care is, but it's also about the cost and that barrier. And I think, going out into the community where the burden of disease is and using AI in a rapid diagnostic way. I mean, the fact that we now have portable x-rays, little machines, these are great advances. And I think we need to, kind of embrace those to reduce inequity and enable access for children who haven't had access or where perhaps access hasn't been optimal. Perhaps I can talk to the issue of preventative treatment that you raised, Justy. I mean, we know that preventative treatment is so badly done in children. It's last on the priority list. I mean, even in South Africa now, we just published, we've got a birth cohort where we follow these children from birth. Now the children are 10, 11 years of age. The children are relatively well. None are HIV infected. None have severe malnutrition. But we found incredibly high rates of TB disease and TB infection in these children, sort of an annual risk of infection of around 11%. And around 10% of children develop TB disease in the first 10 years of life. Now, this is in an area where there's a strong primary health care program. So you think these children, in fact, would get good preventative therapy? No, 90% of children who were tuberculin skin test negative but didn't have TB disease did not get preventive treatment.
We are very grateful for all the insights that you've shared and the experiences you've shared in the past. We are committed as a digital health company to make a difference because I think it's unacceptable for 15,000 children to die every day in the under 5 age group.
Yeah.
So we are also looking at point of care ultrasound, looking at from prevention to post-TB lung disease. What can we do as a digital health company in pneumonia, TB, that space? So it's been really grateful, and we are hoping to continue to collaborate and learn more from all of you. Thank you so much for your time.